pretty good. Just put an R next to it.
I will go here
Okay,
if you don't mind.
that's good. Okay. Your font is bigger on the left than the right. You see that?
Yes.
So this
Yeah,
means
it's really interesting both.
Yeah, and then one of the things that we try to look for with, especially with Parkinson's, is if your handwriting gets smaller over time. It's called micrographia.
But it didn't.
But yours didn't.
Well,
Yours didn't.
yeah.
That means just you're maintaining that function, and then but you can start to see a little bit of breakdown, like less lack of smoothness, right?
Mm-hmm.
Most people that use their left hand aren't going to be exactly as good as their right hand, right?
Yeah.
You don't really have tremor, all right? And then hold it on this hand first.
I see tremor here too.
Everyone has a little bit of tremor.
But you know, I think it's, I'm kind of, yeah.
So with a handwriting examination, you typically have a patient repeat a sentence 10 times and just write it down with their right side and do Archimedes circles left and right. Now, we know she's got left-sided Parkinson's disease, but she's right-handed, so instead of having her write out an entire sentence, I just have her write down the letters of the alphabet, A through G. Now, you can see right away there's a big difference in font size with handwriting. It's much larger on the left than on the right, and even with Archimedes circles, you can see that it's much larger. So this just happens when people lose motor coordination pathways when they have Parkinson's disease. Now, a key feature of Parkinson's disease with many people is they get micrographia, in which the handwriting gets small over time. That's happening because they're getting more rigidity and tightness as they have repeated motor activity being their handwriting. Now, with her, we're not seeing any signs of micrographia, and we're not seeing any signs of macrographia. Macrographia is defined by handwriting getting larger. Even though there's a difference between right and left, this is not macrographia, meaning in large handwriting, macro, or micrographia, M-I-C-R-O, smaller handwriting. But we do see some signs of tremor, and when we look at her hands, we can see some increased signs of tremor. And I can tell you, throughout the exam, you're going to see her expression of tremor much, much worse. And the exam is taking around 3 hours. We're not going through all the different sections of the exam, but there are some videos you'll see as we go through the exam where her tremor starts to come out more as her brain gets more fatigued and her dopamine medication starts to wear off. Keep going. Now, as you're walking, do you feel yourself going to one side or the other? Do you feel yourself swaying?
I feel swaying.
Just walk and see how you feel. Just notice, see if you notice.
Yes, I feel that I'm swaying to the right.
You feel like you're swaying to the right? Yeah.
Yes.
You feel that?
Yeah.
Okay. Do you feel any tightness as you walk? Just keep walking.
I feel some tremor and a little bit on the left and tightness. And a little bit tightness on the right as well, actually.
Okay. And we have to make a note, it's 4 hours since your last levodopa.
Yes.
Okay. Thank you. If you keep walking. Now, is your tremor coming up more as you walk?
Yes.
Is that a normal thing for you?
No. I used to think that I don't have tremor, and I think I start developing a little bit.
When was the last time you went 4 hours since your medication?
A long time ago. I'm taking every 2 hours, which is probably too many.
Okay, there's several important key concepts that we need to talk about in this section of this gait analysis video. First of all, Svetlana decided to not be on any medication for the examination. This was her decision. So she's been off her levodopa for 4 hours. She's never gone past 2 hours. So we're really seeing some expressions of her Parkinsonism that she hasn't even noticed before. Now remember, she was diagnosed with rigidity, akinetic rigidity type pattern, which means she doesn't have any tremor, but you can clearly see even with the handwriting test, she's starting to develop tremor. Now, when you see her walk, you can see that, first of all, she has reduced arm swings, and the reduced arm swings get worse because as she continues to walk, she becomes more rigid. And then eventually she starts to have tremor start to express, especially in that left hand when she's starting to walk. Now, this is really, really important because this is just a clear representation of mitochondria failure. So when the brain, basal ganglia striatal pathways are not able to efficiently produce ATP, they can't gate the basal ganglia patterns that then impact the expression of Parkinsonism. So you can see just walking up and down the hallway for, maybe 3 or 4 times, you can see her Parkinson's directly getting worse in front of you. You can see that her arm swings are limited in the beginning, but they're there. And as she walks, she gets to have that rigidity develop, and if she continues to walk, she gets that tremor in her hand. Furthermore, when she's walking, it's really clear she's unstable. Your biggest clue that she has instability, before even asking her about it, is she has a scissors gait. So when people have instability, they either have a wide stance gait to prevent themselves from falling, or if they're swaying and falling to one side, they'll just scissor their gait. So you'll see when she walks, she constantly crosses her legs. And I could visually see her shift her body, and this is why I wanted her to tell me if she noticed any shifts, because I wanted to see if she was able to perceive it and then ask her about it. So we can see that she's just got some lateral postural instability. Anytime you evaluate someone with Parkinson's disease, you want to see, do they have any kind of shuffling gait? Do they have any kind of freezing? Does their facial expressions change? Do they become more mask face? Do they start to get a dystonic posture? You also start to see that her angulations of her elbow in both the left and right starts to show more of a rigidity, more of a stiffness-like pattern. Now, there's another gait analysis video right at the end of the exam, which should be about some time after her medication dosage. But you can see how she starts to really deteriorate away when she does any type of motor activity, which is letting us know that her mitochondrial system is off. And one of the things we may clinically consider working with her case to improve off and on days, is to improve her mitochondrial fuel source, which will be making sure she has healthy amounts of oxygen getting to her tissues. So make sure her lungs are okay, make sure that she doesn't have any types of anemia, make sure her circulation's okay, her blood flow's good, and all the different various factors that can optimize mitochondrial efficiency and reduce things that cause mitochondrial uncoupling. All the things we talked about in the Crosby Institute fatigue and pain course related to mitochondrial optimization. Come on back. And just keep walking normal.
Okay.
This time when you come back, I want you to count by threes.
Count
By threes.
like 3, 6,
Yeah.
9, 12, 15, 18, 21, 24, 27, 30, 33, 36, 39, 42.
Okay, just walk normal. Don't worry about counting.
Okay.
Now do you feel yourself going to the left or to the right? Because it looks like you're going to the left when you walk. Tell me if you notice any sway.
Yeah, now I agree with you. Now I feel it's more to the left. Because different area of the brain.
Yeah. Okay.
Will get.
So when you look at her gait analysis with double tasking, and with double tasking, you basically have a person typically do every letter of the alphabet, but for Svetlana, we just had her do numbers and make it much, much more simple. But just that cognitive task of doing numbers, which really activates the frontal cortex and inferior parietal cortex, you can see that her tremor on her left side just got dramatically worse. She has slowness and rigidity that were made much, much worse. She became much more unstable. And these are just showing us how little endurance she has in these neuronal pools and how limited her resilience is to cognitive tasks and how quickly her Parkinsonian patterns show up with anything that stresses out or activates her cognitive and frontal lobe processing centers. So this lets us also know that clinically we may want to really focus on improving her physiological pathways that impact her brain endurance and see if that can help her with her overall lack of resiliency to anything stressful or anything cognitive that really makes her have more off days and causes greater expression of her Parkinsonian patterns. Go as fast as you can. And both hands like this. Okay. Now and go finger to finger. And then next finger. Like this finger, then this finger. There you go.
Oh, one.
This one, then this one, then that one.
Couple of times each?
Yeah, a couple times each. And then keep doing that over again. Just want to see. You just keep slowing down, or you keep the speed. Okay, put your hands straight out, and then go like this as fast as you can. Fast, fast, fast. Fast, 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 fast. Keep going, keep going. And then elbows in. And do the same thing, fast as you can. Okay, now put your hands up. And I'm going to have you touch your nose. Touch your nose with just this finger right here. And this one. Perfect. We do the same thing, but with your eyes closed. And I'm going to use this finger. And this finger. And one more time. This finger. And this finger. Now, let your hands come down. Keep your eyes closed.
Oh.
Do you feel the eyelids?
Do I feel what?
Do you feel eyelids tremoring?
Yes.
Okay, so when you see the rapid motor test, you can see that for someone who's got Parkinsonian disease right now in her current state, she's actually pretty good. She doesn't have any significant patterns of hypokinesia. Now, when she does have an off period, she actually does have rigidity and freezing, as noted in her history. So right now we can see that she does have fluid movement. Now, when you look at her left side, you can see her left side is not as fluid as the right. And it's also possible to misinterpret some of her symptoms of like dysdiadokinesia being cerebellar based, but there's a significant change in her angulation on her left arm compared to her right arm, and that's because of increased tone. And that increased tone is going to make it much harder to supinate and pronate, which may look like she has dysdiadokinesia, which is cerebellar based, but it's most likely just related to having a delay in speed and coordination, really just due to her rigidity. Even when you looked at her gait analysis, she's got some patterns of leg dystonia, which could be impacting her balance. Now, there are people that have Parkinsonian disease that have alpha-synuclein and Lewy body disease that develops in the cerebellum, but the problem is with the physical examination, you can't always test or discriminate between these with the current test that we did. Well, if we get a chance to really look at her vestibulo-ocular reflexes and see if she's got any patterns of nystagmus or any signs associated with cerebellar disease, at that point we know that she may have some proteinopathies in her other regions of her brain. But for the most part, she seems to be doing pretty good with the rapid motor testing. You can also see that she's got some eyelid tremor in her eyelids. Now remember, people that have Parkinsonian disease, they usually get rigidity in their facial muscles and don't blink as well. But there are times that they also have some of these tremor-like effects in their eyelids. These are not called blepharospasms. Blepharospasms is something completely different. It's a term that's inappropriately used in the functional neurology world all the time. But these are just eyelid tremor. I'm going to give you a pull like this. Okay.
Should I keep my leg together?
Actually, come over a little bit. Take one slide over this way. Yeah, feet together.
Or together?
Comfortable, just like that.
Mm-hmm.
And close your eyes.
Mm-hmm.
And I'm going to do that one more time. Eyes closed?
Mm-hmm.
Okay. Now just put your feet together. Just want to check your balance.
Mm-hmm.
Okay. Now put your right foot directly in front of your left foot. Eyes open.
Eyes open.
Eyes open.
Mm-hmm.
And just stay there. And then close your eyes.
Mm-hmm.
And you feel like you're going to the right?
Yes.
Okay. And then other way. Close your eyes.
I was with closed eyes.
Okay, perfect. Okay. All right. What I want you to do is take a couple steps back, walk backwards. Are you okay doing that?
Yeah.
Okay. Now put one foot in front of the other, eyes open, and walk across the room. That's pretty good. Come on back.
The same way or no?
Yeah, just like that. Does that cause any problems for you? Any problems with that for you?
No, I think I can do it.
Okay. Now do it with your eyes closed.
Back
Yeah, one foot across in front of the other.
or front?
Yeah. Like you're walking on a balance board. Eyes closed.
Can I have my arms?
No, just leave it there.
Okay, can I?
Okay. It's pretty good. Okay. Does that give you anxiety?
A little bit, yeah.
Does that increase your tremor?
Yes.
You feel the tremor getting worse after that?
Now it's okay. Now it's come down.
Okay. Let me have you stand just on your right foot. And then eyes closed. Okay. And then eyes open. Just stand on your left foot.
Oh, 1 second. Let me.
And eyes closed. Okay. Easier for you on the left than the right?
Well, it used to be opposite.
How about right now?
Okay.
Go ahead and just feel it out for yourself.
Eyes open now.
Okay. How does it feel? Right to left? Is there a difference?
Right. Now I think right is easier.
Right's easier? Okay, try the left foot.
Yeah, right is easier.
So the pull test is basically an evaluation to see if a person has lost their postural reflexes. And this is a standardized test that they use with patients that have Parkinsonian disease. And if you look at some people that have Parkinson's disease, they're hunched over and they're flexed forward. And it looks like they're in severe kyphosis, but there actually is nothing wrong with their spine. This is a condition called camptocormia. And this camptocormia occurs when a person that has Parkinson's feels like they're falling backwards. So they just reflexively bend forward and they don't even know that they're bending forward. And the way to find those patterns in the early state is to do this pull test. Now when you do the pull test, you basically get behind the patient like you saw me do and just give a little tug with their eyes are closed. And they should not fall. And they should be able to keep their balance within 3 steps. Now you can see with Svetlana that she basically fell. I had to hold her each time. She took 1 step and basically would have fallen backwards if I didn't hold her. So this is a positive pull test. You can also start to see some of that camptocormia, that hunchback presentation with her in the very early stages. It's guaranteed 100% for it to get worse because she's got an abnormal pull test. So with time, we would expect to see that flex posture. Now we look at her test for stability, they're actually pretty good. Some of the instability could be just due to some of the leg dystonia that she may have. But she's able to walk in a straight line pretty well. You definitely see when she has a new task and initially starts tasks, her tremor gets worse. So this is letting us know again what the integrity of her brain mitochondria, that some of her Parkinsonian symptoms can be promoted and some of her anxiety could be promoted as she gets any type of motor or cognitive task. So tell us what you're feeling.
Okay, so first of all, so this is kind of typical dystonia on my left arm. It's kind of L shape. I did know that I have tremor, but today it's kind of a little bit different stage because I am much longer without medication than I usually am. Yeah. But the positioning of left arm it's typical.
Okay.
My right arm, which I thought that my right side is unaffected, but I feel that it's rigid, and I start feeling some kind of tingling in the right.
On the right side.
On the right side, yeah, on the right
Arm?
fingers.
Fingers. Okay.
Yeah.
So you're now at 4 hours and 45 minutes from your medication. You just took some levodopa. Right.
Yeah, I
Just a minute ago.
But actually, what might happen? I took levodopa, and recently levodopa actually, instead of relieving my rigidity, it goes into opposite direction.
So your spasticity get worse.
Yes, I believe that this is what we see right now. Okay, let me try to not to fall back. Right. So yeah, I think that this spasticity is the result. Yeah.
Okay.
It just stiffens. My left arm stiffens.
And when you get lots of emotional stress and your catecholamines and stress hormones go, this is how you feel.
Yes.
That'll convert to a bad day, off day.
Mm-hmm.
Whereas a normal day, the levodopa would be fine.
On normal day it should be fine. Yeah.
Yeah.
So on normal day should be fine, and also after even on normal day, the longer stretch of time without levodopa also may cause some kind of dystonic effect because
Right.
probably some.
So normally it's every 2 hours, you were saying?
Typically I take 2.5 hours.
Okay. All right. Well, let's see how you respond and just relax.
Well, I'm afraid I may be in this condition for a long time.
Do you feel like you need to walk? Does that help you? If you walk or if you stay still?
Let me see. There is a lot of things.
Just make yourself comfortable.
Ha.
Best you can.
Yeah. So my most rigidity, then I move, so my leg actually now feels quite, not very tight, but the rigidity comes on the upper part of my body, on the shoulders, and kind of hunch me down, and then you're in this position, you lose balance and it's hard to move. So yeah, sometimes when I'm hiking in this condition, I do like something like this, or put my arms on the back and try to kind of move
to release the
shoulder
pressure.
to release shoulder, and then that's the only position where I can actually hike until it goes away.
Okay.
Because if I leave my arms, it goes back to.
Okay. Do you want me to just finish the exam? Do you want to rest?
No, we can finish the exam.
Move, or what's best for you?
It's hard. Moving a little bit is easy.
Okay.
But I honestly cannot predict how fast it resolves. It looks like it probably is not getting worse.
Okay.
I feel that it's kind of slowly getting better. So another thing I should mention, I kind of remember it now. Then I go from the rigid position to relaxation. I feel kind of in the left ear, I feel some, how do you call it, not noise, but some ringing.
Oh, you have some ringing.
And some kind of like cold feeling. Yeah, this is kind of interesting, but the relaxation comes with the feeling of cold sensation in the body instead of warm.
Okay.
So it's like feeling the circulation is getting worse, but at the same time it's relaxing.
I'm going to time you just walking for a minute. Can you just walk for a minute? I just want to see if that helps change it. Just walk however you like. Just walk anywhere you want.
Right.
Just want to keep you moving for a minute.
In fact, usually what helps better than I start jogging at home, because like fast movement, easy to break.
Go ahead and jog and move around as much as you need to. There you go. Perfect. I mean, typically movement will reduce rigidity.
Yeah. And do this.
You do that? That works?
Sometimes does, yes, sometimes no.
Okay,
Sometimes
okay.
it could be too much.
Okay, let us know how you feel.
So I may add a little bit of the fast acting, or maybe half of pill. Sometimes it goes to the rigidity first, but much faster, and then to better relaxation. It's air conditioning. I was near air conditioning. I start feeling some cold sensation. I hope that it was relaxation.
Well, I turned the air conditioning off. That's the air filter going on.
Oh, I see.
So you're taking more dopa, L-dopa?
I took slow release.
I see.
You know, it's now. I mean, I really don't know what does what. That's why I'm kind of. So this is so much about consistency.
Yeah.
With me, yeah, I hope with food it would be easy, but with medication I cannot do this anymore.
And when was the last time you ate?
Actually, I didn't eat today. I just had some nuts.
You haven't eaten today?
No, I mean I have something on the right arm. I feel it.
You feel like tightness?
Mm-hmm.
Okay.
That unpleasant discovery, but.
But you pushed it a little bit today. It's just
Yeah.
nothing to eat, and also a little bit, longer.
Yeah.
For your last dosage.
So I added half of pill of instant release levodopa, which make me immediately tighter, but there is a potential that it start relieving faster, but we'll see. So now you know my life. Every 2 hours I'm taking pill and kind of keep my finger crossed because I don't know what goes
Yeah,
after.
and this would be off. This is your off pattern right here.
Yeah, this is my off pattern.
Yeah.
Mm-hmm. It's actually so it goes to this extent. I think last week or two maybe.
But it can get worse than this, you said, right?
No, sometimes it gets worse than this. It may put me in dystonia. I mean, in real bad dystonia, like painful dystonia. But this repeatedly rigidity with each pill, it's kind of recent development, and I believe that it's like, I would say, I don't know, like a immune reaction or something. So it's not. I mean, neurology, they call it, without explanation of mechanism, they call it resistance to medication, but I didn't see much paper which explain what does it mean to get resistant. I mean, what the mechanism of the reaction, but it kind of clearly the reaction to the medication,
right?
Not to the condition.
Yeah.
And basically, then they do the surgery in Switzerland. They kind of cut this pathway to the inhibition part.
Yeah.
And people say that they feel in the unit with ultrasound, like they do like few buzzes, short buzzes, and after like first or second buzz, the rigidity goes away, and people stop getting this off condition, and nobody has rigidity. But what frightened me that you never know what else may happen after they permanently have some pattern.
That's the big question. That's what I would think about too when I hear about it.
I kind of hoped initially that this would be the way to go. Then I start reading, people start saying that in a couple of years the off start coming back.
Right.
And after that it's repaired, right? Because you already permanently lesioned part of your brain.
Right. Well, your facial tone has already changed a lot.
Yeah.
The last couple of minutes, you feel the difference in your tone, rigidity. You can see your mask face is gone.
And I feel that
the chocolate's a magic thing.
So what do we do with chocolate, doctor? You didn't mention it.
You have to eat it.
I guess so.
Well, we'll figure out. There's keto chocolate. Have you seen it?
I think chocolate is a keto by design because the sugar content is very low, but the fat is high and flavonoids are high.
Yeah, depends on what kind of chocolate you get.
Yeah, so this is 85%. I mean, So what total amount of sugar on like carbs are allowed? On
So
a
you want
keto-
to
on a
keep under
keto?
20 grams of sugar.
20 grams.
40 at the most, 40 to 20. So
Yeah.
you can see chocolate quickly gets you there.
Chocolate, yeah, chocolate. Yeah, I agree with you. But keto chocolate means that they put some like I don't know, like
There's like
mannitol
coconut
or
oil in there.
no, but there should be some sugar. But is there some substitutes?
It's a substitute. But it still has the cacao
Yeah.
in there. I'll send you a link.
Basically.
You have to, it's like really oily.
Mm-hmm.
You have to mix it and then put it in the refrigerator. And then it gets hard. But I mean, if you're really off, you might just have to have some chocolate, you know?
Yeah, sometimes actually I use it as an emergency.
We need to strap some chocolate in on Alex.
Yeah, actually it's getting better.
Yeah, you can tell.
Less with
You can
chocolate.
just tell from your facial tone, like your expressions are coming back.
It's amazing. I think it's partially because this kind of maybe flavonoids and fat and a little bit of sugar and also the kind of the pattern which brain created.
Yeah.
Which is also better, right? I kind of create some what's the name of like dependence on the drug.
I mean addiction?
Yeah, I'm creating some addiction to get rid of other addiction. But yeah, I cannot.
So it doesn't look like you're going into a overactive high dopamine response,
Yeah,
which is good.
but basically, I think the reason also why I'm taking pills so like every 2 hours, and I obviously don't need it that often. That first, then I'm taking the pill, it kind of make me higher, and then it goes back to the normal. So part of the dopamine is getting used to for the negative result, right? So that's why.
I don't think you'll ever get it perfect though, you know? Like there's always gonna be some of that.
Yeah, still not getting normal.
Let's give you a couple more minutes and
No, it could be more. Sometimes I'm taking the pill. So actually, my bad days could be like sometimes I could be in bed, painful dystonia all day. I'm taking pill by pill, and it always goes into the bad dystonia. But sometimes it just putting me like mild type of dystonia. So it's something like this. I'm taking the pill, and for first hour I'm rigid because of the excess of medication.
yeah.
Then it getting a little bit better, and then it getting worse again because of the lack of medication.
Right.
Then I'm taking next pill, and the pattern is so basically the full day I'm taking pill by pill, and it's not moving because of too much, not moving because of too low. So that's like I'm sitting like this the full day.
Okay.
Unless I kind of can start moving at some point, and then it will resolve.
Well, let's tape you walking again. Now that you had some L-Dopa in you.
Okay. You see, chocolate is gone, and my brain asking for more. Yeah. Dystonia worse than off. You feel it, right?
Yeah.
That is kind of excessive medication.
Do you feel your tremors gotten easier since you took the L-Dopa?
Tremors is less because it's all kind of gone to rigidity.
Yeah.
But the restriction in movement is much worse.
It is much worse?
Mm-hmm.
Can you just walk normally? Just a few times?
So now I feel that my breathing like I cannot even breathe normally.
Okay.
So getting more and more rigid. Okay, so now you will witness my facial.
Yeah, I can see you shuffling more now.
Mm-hmm.
And then,
Yeah, I'm shuffling. Then I am on excess of medication.
Excess medication, yeah. You see the difficulty with turning around the corner.
Mm-hmm. Yeah, because actually I have like the full slow release pill and half of instant release pill.
Yeah.
So, and slow release pill kind of already increasing concentration up to maybe like half of, and on the top of this I added,
Okay.
fast release. So we're dealing with significant excess.
So in this section of the exam, you can see that we had to stop and decide whether we wanted to continue because she was getting a lot of rigidity. So she had decided to go off her medication. She usually takes her medication 2 hours, every 2 hours, but on her own, she decided to be off her medication during the examination. So she was 4 hours and 45 minutes without a medication. And she noticed a couple of things. She noticed that she actually does have tremor, and she's actually getting some expressions on the right side. Now, when you look at Parkinson's disease manifestation, it typically starts with some kind of stiffness or rigidity, either like a frozen hip or a frozen shoulder, and then it progresses to tremor on one side, usually like the hand or the feet, or sometimes even the lips. And then it's usually on that same, so let's say on the left side or right side, but on that same side for a period of time. Then it spreads to the other side, and then it goes and spreads from, the left arm to the left leg, to the right arm. They can even start to have expressions on her face. Now, if you look at her history, if you look at her visual appearance, you can see that she doesn't have any loss of facial tone yet. She's blinking throughout the conversation. Some people get mask face when they get rigidity in their face. She doesn't have any of that, but she does notice that she is worse than she has realized in the past, but she's never had a window of time to really assess what's happening because she's been on her medication off and on. You can also see that chocolate has really helped her. Chocolate is a natural way to increase dopamine levels, and it works on different mechanisms than some of the medications. And that she found that's helpful for her. She's also hypoglycemic during the exam, which is not good for brain endurance issues. So having her eat was important. Now, once she started to get into her off pattern, and this is part of her off pattern, sometimes she states she does get more rigidity in tone that is debilitating for her. You can see that shuffling gait. You can see her gait isn't as efficient. She doesn't have that leg swing like she does. She's just basically shuffling around the room. Her arms are much more rigid. You can see that dystonia starting to take place. She also complains of decreased breathing or difficulty breathing, and that happens when there's rigidity of the rib cage. So we're going to really check her chest expansion and her lung function, but more than likely it's just rigidity of her trunk muscles that are leading to impaired chest contraction. So it's a really good real-life example of what one person's Parkinsonian patterns can be expressed as off and on days, and for her it's really unpredictable at certain days where she's having these patterns. And hopefully if we can do some things to make her brain more efficient, her mitochondria more efficient, she'll have greater endurance throughout the day and potentially have more on days and less off days, but time will tell. When you have the dystonia, how does your dystonia happen with your upper arm and your lower arm? What kind of position do you get in?
So maybe I don't use this word correctly, but I call dystonia a number of different things.
How about your positioning?
So sometimes dystonia is then I just all rigid on the left, and position is kind of nothing changed.
Nothing changed.
But then I'm in dystonia, like in no dopamine dystonia.
Mm-hmm.
It's usually goes like this, my left arm.
Your left. Anything with your wrist?
And
Does your wrist impact or just your elbow?
usually, I think I don't notice wrist. I think it's mostly
Just your elbow. And
yeah.
your shoulders okay, or your shoulders frozen too?
Shoulders. No, in low dystonia, it's. I mean, in low dopamine dystonia, it's doesn't raise. But in high dopamine dystonia, it raises and the arm can go up.
Yeah, for you though, it doesn't do that.
In high dopamine, it does. I mean, then I
see. When your dopamine's high, it does that.
then I take over medicated, but then under medicated, it's like this and
I see.
and I'm hunching.
I gotcha. And how often do you get high dopamine?
High could be quite often. I may take medication, and it just if I'm overexcited, I think if my brain already kind of in high excitation level,
yeah,
I'm getting into dystonia right away after I'm getting medication.
Okay. And what about your leg? What happens to your leg when you get? Do you get any posturing in your leg?
Yeah, so actually dystonia happens with right and with left leg.
Oh, this one is
And
both legs.
in fact, sometimes it starts with right leg and feet,
Okay.
and then it goes to the left leg,
Okay.
and they kind of.
Your ankle turns in. Can you show me?
No, it's not near. So my right leg usually go the foot got like this, and then the hip
Yep.
turning over.
Hip turns out.
Turns out, yeah.
Okay.
And left usually, in left it's mostly toes,
Your toes.
and the position of the leg doesn't change.
Your toes curl.
Yeah, toes crows.
Okay. And then when it gets really bad, do you feel the pain in?
Oh, it's very painful, yeah.
Okay. But nothing in your face and neck.
My face, no, actually I had neck. I have neck too sometimes, and face start grimacing recently. Each time, most of the time, then I take medication, I start having. I think it's dyskinesia on the face.
So in this part of the exam, she's just explaining her dystonia. And when you look at dystonia, she defines dystonia as just tightness and rigidity. Dystonia typically means abnormal tone, dysfunction in tone. It can be with angulation or without. Now, some people just use rigidity as a term where there's just tight, and dystonia when there's actually angulation. But in any case, whenever you have a patient has any kind of tightness or rigidity, you want to really map out where they're having it as a baseline. So you can see that she's got some significant changes in her limb posture in her left arm, and then it goes into her right leg, left leg, and even goes up into her right hip. She doesn't have any types of rigidity in her facial muscles. She complains about a little bit of her neck. She doesn't have a lot of dystonia in her right arm. Then she also brings up the point that sometimes she has high dopamine or low dopamine patterns, and there's a term in Parkinson's disease called the Goldilocks effect, where you're trying to get the perfect amount of dopamine for balance. And sometimes when there's too much dopamine activity, you can get symptoms, and sometimes there's too little dopamine activity, you can get symptoms. And these are mechanisms that aren't completely understood yet, but there are patterns when she explains that she's excited and she takes her medication, and then she can even get more rigid, and then she'll notice that the rigidity goes into her shoulder. So with any patient that has Parkinsonian disease, you want to get a baseline of where they are with their patterns and their symptoms, and then compare that in the future to see if, for example, is her right arm starting to get involved now? Is her left hip involved? Right now we know it's just her right hip. So mapping out the patterns of dystonia are important. If you can stay here for the next year or two, that'd be great. Now remember, this is a progressive disease, so over time we'd expect more rigidity and tightness in other limbs, and that would be an indication that that somatotopic map is getting more progressed with Lewy body disease from the expression of her Parkinsonian proteinopathy buildup. Now, if you just stay there, if you close your eyes, if you picture yourself standing really, really still, like you're not falling or moving, does that change your tremor?
I'm trying to relax and see. Well, actually, if I kind of straighten my...
Yeah, but don't do that.
Oh, don't do it. Only imagine.
Yeah.
It makes it less.
A little bit less.
Okay. A little bit less, yeah.
So this part of the exam, I'm just checking her parietal lobe function by having her perceive her limbs and see if it's having an impact on her tremor. Now, we know any type of motor task, like when she was walking with gait and double tasking, or you trying to keep herself stable, that her tremor got worse. Any type of cognitive tasks tend to make her tremor worse if it's challenging enough. And now we're trying to find some ways to see if activating different areas of your brain can have any impact, either increasing or reducing her tremor. So when she visualizes different body regions, there's some reduction in her tremor. Now, we may use this as some kind of therapy for her, but it just also lets us know that her parietal lobe is intact, and she does have some ability to activate other centers of her brain to manage her tremor, which also means that if her brain becomes healthier physiologically, that may have an ability to reduce some of her Parkinsonian symptoms. If you take your foot and just move it in different directions, your left foot, and just like move it in different directions, try to do like different letters, different numbers. Do you feel anything different in your tremor?
Then I'm doing in certain direction, it lessens, but in another direction it
Which
doesn't.
direction is it less?
Okay, so cannot quite. I think it happens that I'm changing direction.
When you change direction?
Yeah, I'm doing like left and right.
So here I have her move her left foot in different positions, and I'm using her left foot because most of her symptoms are on the left side. So complex pattern movements activate that ascending dopaminergic projections to the striatum, and that may have some impact on modulating some of her patterns. Now with her, she only notices a difference, she says, when she starts to go from one direction to the other, but you can visibly see that it's not helping. If anything, it's making her tremor worse. So again, just trying to see if there's any things we can do to increase or decrease her tremors. Obviously, we want to find stuff that can decrease some of her tremors and maybe have her do those types of activities. And we're going to go one side here.
I don't move the only eyes.
Just the eyes. Just look straight like that. Tell me if that makes your tremor change at all. Same or different?
I think it changed at some.
And
Stop now.
let's keep doing a little more.
In the end, and it goes to the end. Now it's so like first few times, then like after the half of the tape, it's stopping. It was stopping. And now it's probably better.
Let's go the other way.
Same. It stopped first 1 or 2 times, and then it probably gets tired.
Okay, so just a couple, and then you see some benefit, and then it's done.
And then,
Okay, and let me just check your vertical. Just look straight ahead. These are really good movements. These are what you lose in supranuclear palsy, but yours are perfect. Did that make a difference? Same?
It a little bit, but during this exercise program it worked very well. But I was on the pill.
medication.
Yeah.
So optokinetic testing is a way just to check reflexes that are generated by different regions of the brain. So when you look at the basic ganglia has a motor loop, a limbic loop, and an oculomotor loop. An oculomotor loop is pathways that are involving eye movements. Now, a couple things to note here. In her history, she noticed that when she worked with some people that did neurological rehabilitation, she had eye movements and felt great and then crashed for a period of time. Now, what we're seeing with her is that she does have healthy, what I call optokinetic reflexes. When she looks at that red and white tape, it mimics as if someone was looking outside of a train and seeing things move one target, then the next target, and then the next target, and the eye has that quick saccade activity, that jumping back and forth activity. And she has those both horizontally and vertically, which is fantastic. Some people start to lose those with Parkinson's disease, but hers are intact. But she does fatigue, and she notices it has some impact on her tremor, but within a couple movements, then she notices it's actually fatiguing her brain and making her tremor worse. So this is a clear sign that she does not have efficient mitochondrial reserves, and she's quick to fatigue. This is probably the reason when she worked with some other people that were doing brain rehabilitation rehab with her, she completely crashed and fell apart. So we're going to definitely need to look at clinical strategies to improve her mitochondria and see if that can help her with her brain endurance throughout the day. The second part of the exam that's really important is whenever you see someone who's got Parkinsonian disease, one of the things you always have to rule out are things like supranuclear palsy. Progressive supranuclear palsy is a presentation where people lose their vertical eye movements first and their vertical optokinetics, and hers are intact. Now, most people that have supranuclear palsy, which is a more severe form of Parkinsonism, don't respond to L-DOPA. So we know that she has the classical pattern of Parkinson's disease where she has rigidity and stiffness and responds to L-DOPA. She has no signs of cortical basilar degeneration. You can see her executive functions, her frontal lobe, her ability to communicate is all intact. Just follow this. Perfect. So you can see that her visual pursuit and tracking is intact in all directions, which means all of her oculomotor muscles are working, and her cranial nerves 3, 4, and 6 are functioning well. She has no slowness of movement. She has no catch-up saccades. Everything is healthy with her visual pursuit function and those centers of the brainstem that are involved with this. And flex. And extend back. And flex. Okay. So you can see I'm having her flex and extend her neck just to see if she's able to have proper vestibulocular reflexes when she's looking at a target. And you can see a lot of rigidity in her neck muscles. So we can guarantee with this finding in the pull test where she was falling backwards with just a pull on her shoulders earlier that she's going to develop some captocormia, that hunched posture position. You can already see it develop here. You can see that severe anterior neck carriage and that humped shoulder. Those are going to occur as she continues to lose her vertical postural reflexes. Now, her visual pursuits are intact, so this again is part of Parkinson's disease but not part of supranuclear palsy. Okay, so this is the lead pipe. Have you heard of lead pipe?
Cogwheel?
It's a cogwheel, little cogwheel in the beginning. But this is like, let go. It's like, and this side is smooth as butter. You feel the difference?
Yeah.
And it gets tighter than this when you get into it. This angulation, obviously, right?
Mm-hmm.
Okay. So that's definitely lead pipe. Let's try your feet here. Ooh, it's really tight. So the tone in this one's a little tighter. You feel the
Yeah, I
difference?
feel it.
This is more of a lead pipe on this side.
So I cannot say it's only left side and then right.
Yeah. So when I do passive stretch of her limb to evaluate her muscle tone, you can see that it's really clear she's got a difference in tone between the left and right side. And on the left side, she's got some significant, lead pipe rigidity. Lead pipe rigidity means it's just having the really hard time moving the arm. If the arms feel really, really heavy, they just won't let go. And then there's also a little bit of cogwheel where there's a little, like the arm lets go and then catches again, lets go a little, and catches, lets go, and some parts of that movement. But it's very clear to see the left arm. But what's striking here in the exam that's very important is that she has it on her left leg and her right leg, which means that the presentation of Parkinsonism is not just spreading to her feet, but also spreading to the opposite side. Let's get these. You feel those muscle twitches in there? So deep tendon reflexes are normal and intact in upper and lower extremity, but one of the things that was highlighted in this section of the video was just tapping her hypothenar area, and you can see that she goes into like a spastic posture. That happens when there's increased tone in the muscle. Now we know with her, the increased tone in her muscle is really due to dopaminergic pathways that are impacting that. But you can clearly see that tapping in her hypothenar area causes that spastic response. So that's called percussion myotonia, and it's found on the left side. Good news is it's not on the right side, but this is a sign that she's really, really sensitive to changes in position, like a deep tendon reflex that can cause spastic patterns. Thanks. Now your neck is like as tight as it could be. Can you bring your neck down? Flex as much as you can. Can you go any further than that? That's as far as you can flex? How far back can you extend? Try not to move your trunk. Let's just keep your trunk right here.
No, but my trunk is, if I sit in normally.
Okay. Okay. So you can see that her cervical range of motion is completely limited, especially when she tries to extend her neck. Now, it's not uncommon for someone who has early Parkinson's disease that does not have tremor yet to get constant soft tissue work, manipulation, acupuncture treatments for a tight neck. And that could be the earliest presentation of Parkinsonian. Now, if you can quickly do an exam and just see if there's any lead pipe rigidity, if there's any chronic patterns of constipation or loss of smell, things that happen, the early signs of Parkinson's disease, like a frozen shoulder on one side, you may have a person that is being misdiagnosed with this weird, strange, chronic muscle tightness pattern, but it really has early patterns of Parkinson's disease. And remember, many people will have rigidity and tightness years before they have any patterns of tremor. So you get some facial dyskinesia when your dopamine levels get low, or?
Well, I usually notice it on the mouth, but you see better.
Okay. So far it's okay. A little bit there. So facial dyskinesia is just small little contractions of the facial muscles, and many people with Parkinson's disease may have them. And actually anyone with basic ganglionic disease may have them. And at different times of the exam, she'll fatigue, and you see some of these twitches. Now with the video shot here, it's not as clear as to see, but you do see some type of movement right on her lower lip fold on the left. Let's just let your eyes relax. Now, tapping on the glabella, called the glabellar reflex, is typically done by having the patient told, do not contract your eyes, do not blink, and then you tap him. And if they do blink, that's called a positive Myerson sign, which is one of the early findings you'll see with people that have Parkinson's pattern. Now, that's not exactly what I did. What I did with her is instead of telling her not to blink, I just wanted to see, with her eyes relaxed, if she does have any type of blinking reflex. And the reason I'm doing that is because one of the features of facial rigidity is that they don't blink. And this is not the classical Myerson sign. This is just me trying to tap her to see if she does have any type of blinking response, or that her eyelids are too rigid. And for her, again, she doesn't have a lot of facial rigidity, and she has some degree of eyelid movement, even though it's not a full blink. But at the end of the day, it's just a way to evaluate her normal response. Now, whenever you're doing an examination, you should always just look at someone's eyelids, and if they just feel like they're just staring at you and not blinking, that's always a red flag for increased facial tone, which you see with Parkinson's patterns that have that mask face pattern. She doesn't have any of those issues that we're concerned with at this time. Okay, over here. Okay. So the coronal reflex checks the V1 trigeminal afferent pathways, and then checks efferent cranial 7 pathways, and hers are intact. So when we look at her motor brainstem reflexes like her cardinal fields of gaze, which is totally intact, and coronal reflex responses, we can see that her brainstem integrity is pretty good. Remember, as Parkinsonian diseases or any type of neurodegenerative disease progresses, those protein aggregations start to build up in different areas of the brain, and once they start getting into the brainstem, you have a whole series of things that can take place that can disrupt autonomic functions. But her coronal reflex and motor testing were reflex centers that are involving the upper, middle, and lower pontine areas of her brainstem and midbrain are all intact. You can see I'm just quickly checking the rooting reflex. The rooting reflex, if you remember, is a primitive reflex, and just stroking the cheek should cause no contractions of the lips. For people that have not been able to suppress their primitive reflex, you'll see when you stroke their cheek, they'll actually have their lips contract almost like they're searching for a nipple. That happens when the frontal lobe is not actually activating the descending pathways to the motor neurons. But with her, she has a absent rooting reflex, which means that those projections are healthy. Now, sometimes when people have frontal lobe degeneration, like with cortical basilar degeneration or frontal lobe injuries or lack of frontal lobe development with children, they will still maintain these rooting reflexes into adulthood. So now your tremor is just good.
Mm-hmm.
Just resting like that. Does that happen for you?
No, I couldn't say because I don't remember when I was last time in this stage, like 4 hours. 4 hours and still moving, let's put it this way.
So Lana, tell me about you said you can't remember the alphabet anymore.
Okay, so with the English alphabet, honestly, I never learned it properly.
Okay.
Because we started learning language, and I wasn't in this, I kind of missed this stage, like kids, you learn it in your childhood,
Okay.
and you remember it forever. So then adult, I just kind of probably tried to memorize it quickly, but it never stuck in my head.
What about in Russian?
Russian alphabet, I remembered always till the letter T.
Yeah.
Then I was learning this, and then I may know it. I just don't. So what I noticed with my memory that I forgetting things which happened long ago, which I don't use often, like some books, some which I read in school, which I never pay much attention. Something which didn't mean much and which I don't use. This memory I kind of sometimes losing.
Okay.
The same problem was I may still remember Russian alphabet. I have to try.
How long? When did you first notice? How many years ago did you notice you're losing your memory or your ability to remember those things?
Noticed a while ago. Not that I don't remember exactly, but for example, some books, I know that I read this book and I remember something, but not very clear, and I wasn't sure that it's not normal.
Okay.
I noticed it maybe a few years ago.
5 years ago, 3 years ago?
More clear, maybe 2-3 years ago.
2 or 3 years ago. Okay. Now, if you take your hands from this position and keep them like this, keep them there. And then let them rest again here. And now they're fine there. Try to do the alphabet the best you can.
Russian?
Yeah.
A, B, V, G, D, C, G, L, M, N, O, gosh, L, M, N, O, P, R, S, T, U, F, X. Yeah, I think I missed a couple of letters.
Okay. Try in English the best you can.
A, B, C, D, E, F, G, E, K, I don't remember this part, E, K, G, J, L, M, N, O, P, R, S, O, P, R, C, S, C, T.
Okay.
So basically I remember always like a couple of clusters, and I missed a couple of clusters in between. And I think it's pretty much the same that I learned.
Yeah, every time you get a little stressed out, your tremor comes up.
Yeah. I think it's typical.
Yeah. So you can see that there's changes of her tremor. Right now she's sitting here. We've just been doing some very basic motor testing. She's just been relaxing, and her tremor is gone. Now, it's probably been about 40 minutes since she took her medication, and there could be some effects of that. But regardless of that, you can see that she has her tremor turned on when she does cognitive tasks. When she does her alphabet in her native language, there's no significant difference. When she does it in English, which challenges her frontal lobe focus, attention, concentration areas, and her recall areas of her brain, the medial temporal lobe, she starts to get some of her tremor that come back. Now, one of the things that's really important to remember is, her on days and off days, or good days and bad days, she is really have associated that only with her medication. But we can clearly see here that things that impact her cognitive function, her brain endurance, doing executive tasks, and memory and recall basically lead to tremor. And if you can remember some of your basic ganglia neurology, the frontal lobe is what's going to activate and excite the striatum, which can then dampen these direct and indirect pathways that can then control tremor. So what we can see here is a clear example of mitochondrial impairment leading to neurological symptoms. This is real. This is not textbook. This is mitochondrial impairment leading to neurological impairment. And as she challenges those regions of the brain and she doesn't have the ATP pools there, she loses the ability to gate those basic ganglia, direct and indirect loops, leading to the expression of her tremor. Now, ideally, if we can get those mitochondria centers of her brain healthier and can improve things like mitochondrial biogenesis, mitophagy, and autophagy, we hopefully can improve her endurance throughout the day and less off days and less off patterns, unrelated to her medication. Here, arms like that, and we see a little improvement. This is a wing beat position, and then we see what's called reemergence. Or if you keep it there, then the tremor comes out again. That's classical Parkinson's tremor. One of the features of Parkinson's disease is resting tremor, but when you have a person move their arms into a wing beat position, the tremor will go away. And then the tremor will go away for a few seconds, and then it will come back or reemerge. So that's a classical pattern of Parkinson's disease tremor. So resting tremor, and when their legs are on their side, you move their arms up into a wing beat position, the tremor stops for a few seconds, and then you give it a little bit of time, and then that tremor starts to come back and reemerge. So reemergence in a wing beat position is a classical Parkinsonian tremor, and that's how you can clearly identify it. The cover-on-cover test was done. You can see that there's no expressions of cover-on-cover tropias, which we can see with any types of oculomotor dysfunctions involving the upper brainstem, the mesencephalon, or areas of the pontine regions. So hers are intact.
I don't think I can read it.
Yeah, that's good. So you can see her tissue saturation of oxygen is 96%, which is a little bit low. This is most likely due to rigidity of her trunk. We're going to measure her chest expansion and also make sure there's nothing going on with the lungs by auscultating her lungs. But if you remember when she was having some troubles going 4 hours and 45 minutes without her medication, she started to have difficulty taking in deep breaths. And those are not uncommon with people that have Parkinson's, that have musculature contraction or rigidity of their trunk muscles that are impacting their ability to really get expansion of the lungs and fill their lungs with oxygen. It doesn't reflect actual lung pathology. And you can also tell from her blood pressure that her blood pressure she's slightly hypertensive. And you got to be very careful with a lot of the different blood pressure medications, because they can definitely interfere with her muscle tone contraction and her impact with her levodopa that she's having managed with her neurologist and physicians at this time. You like to walk in the jungle barefoot?
I didn't do proper pedicure for a long time.
You make some hikes in the jungle?
Yeah.
Do you walk barefoot a lot or no?
Not much. I used to like it, but now with the dystonia on my toes, I feel they're super fragile.
Right. The skin changes you're seeing the sole of her feet or from her feet shuffling. So if you remember when her dopamine levels got low, before she started to get levodopa and she started to get more rigidity, her gait changed and she started shuffling on the carpet walking around. So when you see this degree of change in her skin, this lets us know that she has some common patterns of shuffling that are now changing the structure of her skin tissue. So she must have significant changes in her gait when her medication's off, and it must happen quite frequently to see these anatomical changes in the bottom of her feet. Should we fill time?
No, I did. So anyway.
They're as white as you can be. See difference? Pink and white?
Yeah.
You can see the pallor of her nail beds and that her capillary refill time is impaired. Now this could be associated with poor circulation. If you also remember, her oxygen saturation was low at 96%, most likely because she has rigidity of her trunk and can't get oxygen to her tissues.
What do you see, blood supply?
Yeah, it's checking your temperature. Just move your hand here. So we look at her temperature of her limbs from proximal or distal, looking at a surface thermometer, we can see about 10 and even 12 degrees of change. Anything more than 10 degrees of change indicates signs of poor circulation. So she has some circulation issues that are there. And that's important to us because when we try to improve endurance pathways for her brain, the ability to get blood flow and circulation is going to be critical so she can really support her mitochondria. Biggest issue we have is we're really in a vicious cycle where she may not be able to get ideal chest expansion to get that oxygen to her brain as we would like. Feel that?
Yeah.
Do you feel that on your legs?
Mm-hmm.
Tell me when it stops. Close your eyes. Tell me when it stops. You still feel it?
Yeah.
Tell me when it stops.
Still feel it.
Do you feel it here?
Yes, I feel it, but not as
You feel that?
no,
Do you feel it here?
no.
Do you feel it vibrate?
Yes.
Tell me when it stops.
Keep in mind that the rules that are war.
Do you feel it here?
No.
Okay. So what you're actually feeling is your tremor.
Really?
Yeah. You feel that?
Yes.
Tell me when it stops. Do you feel it stop?
Hmm.
You still feel it?
Mm-hmm.
Do you feel it?
No.
Yeah. So that's your tremor. Do you feel? Do you feel it vibrate?
Mm-hmm.
Tell me when it stops.
Stop now.
Stop now.
Yeah, no. Don't feel anything. Nothing.
Okay. Do you feel that?
Yes.
Tell me when it stops.
Mm-hmm.
Yeah, but it's here, as I said, the rules
Stops.
So when I'm testing her vibration sense, I can see that there are times when there's no vibration and she still feels movement, and that's her tremor. And we can see that in different limbs. And there's times where a tremor, I don't feel her tremor when I'm doing the test. It's just not as active. And then she can notice that it stops. So I was noticing a clear pattern of her perception of vibration sense. Not so much to what I was feeling in the tuning fork, but what I was feeling with movement of her limb. So you got to be careful evaluating vibration sense with people that have any type of tremor in their limbs, which is what you get to see with this part of the exam clip.
Orange?
Orange?
Yeah, I think it's orange.
Try one nostril compared to the other side.
Don't feel the same. I don't feel it.
You can't tell?
What was it?
Anise.
Anise? Wow.
Saw that?
Yeah. I couldn't put finger on it.
Okay, no problem. Look up here. Close your eyes. So with Parkinson's disease, the alpha-synuclein buildup, which is the pathophysiology of the disease, which then leads to Lewy body development, starts in the gut and starts in the olfactory bulb. Now, Svetlana doesn't have any gut motility issues or hasn't really complained about smell issues, but you can see that she has some difficulty recognizing smell. Now, we typically like to measure coffee, anise, and mint because we're one of the earliest signs of people that have Parkinson's disease that have the olfactory bulb degenerative changes first. Now, we didn't spend a lot of time checking olfaction because we already know she has Parkinson's disease, but you can see that it is impaired to some degree. Also, there's a little bit of facial dyskinesia, there's little twitches on that right lower lip chin area during the examination. Go ahead and swallow. Okay. In this part of the examination, I'm just going through thyroid palpation, and there's no patterns of nodules, swellings, goiter, or any types of abnormal anatomy. Take a deep breath in. Out.
Hold.
Deep breath all the way in, all the way out.
Mm-hmm.
Out. And again. Yeah, it's really hard for your chest to expand, right? Take a deep breath all the way in and all the way out. All the way in, all the way out. Yeah, your little chest expansion's a little limited there. So there's no abnormalities noted with heart or lung auscultation, but there's very clear issues with chest expansion. So when I put my fingers around her rib cage and have her try to expand her chest, there's very little movement. There's lots of rigidity there. So that would explain her difficulty breathing. When her dopamine levels were low, it will also explain why her tissue saturation of oxygen is at 96%. Now, this could be something that really hinders our ability to allow her to recover because, the mitochondria needs oxygen to function and produce ATP. And if she has significant rigidity of a rib cage, she's not going to be able to get the best oxygen to her brain. So again, we'll have to see what we can do, but this is a serious deal breaker that we have to really account for. Without oxygen, sometimes there's no impact from any nutraceutical for the mitochondria because ultimately you have to have oxidative phosphorylation. The ability to transfer phosphate groups to make ATP is totally dependent upon oxygen. So hopefully with some movement and exercise in our daily routine and other factors, we may be able to compensate to some degree, but this is going to be a serious problem, a wrench in mitochondrial optimization when you have someone that has reduced chest expansion due to muscle rigidity from their disease. Do you feel yourself moving or falling to any direction?
No.
Can you visualize your left ankle? Where it is?
Yes.
Can you visualize your right ankle where it is?
Mm-hmm.
Are they easy to perceive on both sides, the same, or
Easy to perceive the
on both
position?
sides? Yeah.
I think on the right leg, I kind of felt it in two different positions first.
And what about the left?
On the left, it's fixed.
It's fixed. Yeah. How about your left wrist and right wrist?
The same. Left I feel immediately, and to feel right, I need longer time.
To feel where the right hand is?
Mm-hmm.
Okay. So we have her perceive where her limbs are in space. We can see that she can clearly note that her left side immediately, but not on the right side. And this is because that increased muscle tone and tremor over an extended period of time has caused greater plastic changes in her somatotopic map. So unfortunate thing is that once the brain starts to develop a somatotopic map of muscles being in place in a rigid plane for a period of time, that becomes very, very hard to unwind. So it's very likely there's going to be some degree of ongoing rigidity no matter what because of that plastic development in those parietal lobe somatotopic map regions of her brain. Jump around like you can, best you can. Your dystonia is really showing up now.
Yeah, I think I cannot even jump now. I guess the best probably now would be to lie down and sometimes.
Okay. So here we have her do gait again at the end of the exam. The exam has taken about 3 hours at this point, and you can really start to see that her rigidity has come out. You can see that dystonic position of her limb when she's walking. You can see when she's turning to walk back, she has a lot of shuffling. When she's walking, she's shuffling much, much more. So you can clearly see the expression of her Parkinsonism get worse in a very short period of time. And you can also note that it's been about 2 hours since she took her levodopa medication, which is the normal time period where she takes medication, but it's not always having the impact that she would like. So this could partly explain that some of the symptoms she's having in rigidity and tightness may not just be directly associated with her levodopa, but really related to just her mitochondrial endurance and integrity that may cause her underlying patterns to be expressed more.